Here we go. Hello again, welcome back. I hope everyone's feeling recharged and ready to take in more content from our upcoming speakers. Delivering high levels of patient care is always the top priority for the NHS, and this is done through effective workforce management. Planning, as well as looking after staff, is a core process that every business, including the NHS, needs to do to its optimum capability. In this discussion, we'll be covering tools NHS leaders need to monitor their staff output and how leaders can organise workflow to suit the resources they have available. So for this panel, I'm delighted to welcome Mira Nair, Chief People Officer at Lewisham and Greenwich NHS Trust, Wendy Preston, Head of Nursing Practice for the Royal College of Nursing, Naomi Keeling, Assistant Director of Workforce, Oxford University Hospital NHS Foundation Trust, and joining us once again, Michael Tressise, Head of Workforce Solutions, NHS Shared Business Services. Please do continue to send in questions and I'll ask as many as possible once I get going. So welcome to this afternoon's panelists. Hello again, Mike, good to have you back. Wendy, can we start with you, talking about the priority issues that are affecting the nursing workforce?
Thank you very much. If I just to summarise that into 4 points, I think it's recruitment and retention, staffing for safe and effective care, and of course pay, which will help support that recruitment and retention. During the first phase of COVID pandemic, we know millions of people across the UK came out to applaud healthcare workers, including nursing staff. And that shows that, the public really values and trusts nursing staff who are at the forefront of health and care services every day in every setting, and working with people of all ages, all communities, dealing with complexity and the fast-pacing changing environment. But what we've seen is a continuous escalation of unprecedented demand for nursing services. I see this daily myself. I have 2 clinical roles as a consultant nurse and as an advanced practitioner working for a 111 service. And we're seeing the nursing workforce continuously be in crisis, with high numbers of vacant posts, a reliance on agency staff, and not enough staff entering the profession due to lots and lots of reasons, both with domestic recruitment and international issues. So retaining that really experienced nursing workforce, but also thinking about how we recruit the next generation. And we're not going to do that without sorting out staffing for safe and effective care and also pay issues.
Gosh, wow, what a powerful opening, and you've raised so many points in there. Naomi, I'm just wondering, what are the main issues that your teams are facing, and does a lot of what Wendy said there resonate with you?
Yes, it definitely does. It's the main issues really are the demand, trying to find the workforce in the first place, and obviously keeping hold of the workforce. I think one of the main things I would raise is really look at that future pipeline, moving away from people leaving and then replacing like for like, but really trying to look forward to the next kind of 5 years and beyond in terms of where that future pipeline is going to come from, and how we can kind of bring in apprenticeships, etc., to kind of grow our own to fill those gaps.
Mira, tell us a bit about the work that you've been doing at Lewisham and Greenwich Trust to try and resolve workforce issues where you are.
Thanks, Helen. I'm just thinking some of the comments that Wendy and Naomi made are absolutely pivotal. So the work around retention, productivity, these are issues that I think every NHS organisation is actually struggling with. And I think every provider in the sector is probably coping with the same things. And there's something about how do you use all these various tools and data that we have to actually make an improvement. And one of the things which I think people might find quite interesting is around roster. So we've been struggling in particular pockets of our workforce. When we look at data around why people leave, what we found is that particular people, many people, and largely staff who are white and senior, leave for reasons of promotion, etc. And more junior staff, who are largely from minority ethnic groups, leave because of work-life balance. And that meant that we took on a piece of work specifically looking at how rosters are set up and what is the impact that has, both in terms of productivity, in terms of spend, but equally in terms of staff experience. And that has been very, very impactful. So we started a piece of work where our healthcare assistants and nurses would jointly, in every ward, design the rules around rosters that worked for that team. And that sort of ceding authority away from a policy to that group to say, you tell us what works for you as a group and we'll design the rosters to fit your needs, has meant that temporary staffing requirements drop, shifts are filled a bit better, people feel that they have got more control, and therefore morale as a result gets uplifted as a result. So something that is often seen as a really simple tool can have some really far-reaching consequences if we just get people involved in the whole design around it. And I think this is why workforce management, although the phraseology can feel a bit dull and boring, I think can have some significant impact in terms of retention, productivity, and EDI.
Well, in fact, it's had such a positive impact. Isn't it being rolled out trust-wise now?
Yes, that's right. I mean, there are various elements of this work that we did. We identified this as a gap, particularly for our healthcare assistant workforce, where they were a bit of an outlier in terms of levels of sickness, high levels of turnover, and feeling unsupported in terms of well-being. So we've had multiple pieces of work. We also did some work with them in terms of one-to-ones. Now, for people like me and for people in very senior roles, if you take it as a matter of fact and as a matter of course that you will always have a one-on-one with your manager at regular intervals. Now, that's not the experience of more junior members of staff. They're very clinically focused. They're absolutely focused on delivering patient care to the patients that are in our care. And that means that there's no time that's carved in their diaries for actual one-on-one conversations, which are about them and their well-being. So those programs that we piloted with our healthcare assistants were so impactful. We currently have a project that we've now got funded for to roll out trust-wide. And the feedback, I mean, I tell this to all colleagues when people ask me about the program, the feedback from healthcare assistants about the one-to-ones was embarrassingly good. I don't expect any feedback for something that I see as a real basic mainstay in terms of management. One-to-one is a really basic productivity tool, is a really basic tool in a manager's arsenal. And to get such embarrassingly good feedback was almost too much. But it has meant that we're now funded to roll out the project organization-wide.
Oh, well done. That's really, really exciting. Mike, I've noticed you've been making copious notes there. I hope it's not a shopping list you're writing, but but I just wondered before I launched into anything specific, whether there was anything there you wanted to pick up on, because obviously so many points were made before I could get to you on this panel. Oh, we just need Mike's mic.
There we go.
You're back up now. Can you start again, Mike? Because we couldn't hear you there.
Yeah. Being the sort of role I have, consultative role, I listen very carefully what people say. And you may have not have missed it, but I was really struck in Phil Wood's presentation. He used a phrase, leading at all levels in a complex organization. So how important it is. And, it's one-to-ones at an HCA level require leadership at a ward level. And we don't really cascade leadership and management skills down to that area. And I was talking about this very topic yesterday. I'm working across North Central London with NCL Partnership, where we've got 8 trusts all collaborating around recruitment. And I was trying to explain to somebody that we need to get sort of people in the sort of team leader level to be more managerial. And one of the team managers said to me, well, that's all very well, but the patriarchal culture in the NHS means nobody feels empowered to go and do that type of thing. And I think some of the examples you've just given, particularly sort of, mirror around bringing that down. It just always strikes me, the NHS is so complicated for lots of reasons. And yet we need to empower people further down in the organisation to make these sorts of decisions, because otherwise you're not going to, solve things like the flexible working problem, because it's a really hard problem to crack. So I'm writing lots of notes, but it's fascinating. But I also think I'm a very positive person. I think there are solutions, and we need to be able to find where something works well. It was interesting for me, Mira, to say that you funded it because it needs support. You can't just say to a bunch of, a ward manager, by the way, you go and do this, go and look at the way you're managing your rotas and your rostering system, get them to allocate and figure out how it works better. Without the space and time to think about it and support, it's not going to happen.
No, and that's presumably part of the puzzle of trying to increase productivity, is it? By taking a step back, Mike, and having that time to think.
Absolutely, and I'm sure Mira and Naomi, and people in that sort of HR director, chief people officer, and all the assistants and HR business partners. It's such a struggle to find time to do anything other than react to what's immediately happening. I mean, for the last, several weeks, 3 or 4 months, we've been trying to do some change programs, and it's impossible because with the strikes going on, then the pay award, and so on and so on and so on. It's just trying to find even a nanosecond to have some breath and step back and think, how can we make this work better? It's so difficult. And the HR community, workforce community in the NHS are the poor cousins of the finance community. Finance directors seem to find pockets of money to invest and sort out finance and accounting and procurement, but it's always a struggle for HR and workforce, who, after all, are responsible for the biggest asset in the NHS, and the NHS is the biggest sort of employer in the UK. So quite possibly the biggest single resource asset in the UK is the HR, the workforce in the National Health Service, particularly nurses and healthcare assistants, and yet they just don't seem to get the attention that other workforce areas do.
Yeah, you're so right. And Wendy, what about the Royal College of Nursing? I mean, how have they supported the development of nursing workforce? Has there been a lot of support from the RCN?
So absolutely, it's one of our priorities, and we launched just 2 years ago now, actually, the first ever nursing workforce standards. So as the Royal College for Nursing, we have 500,000 members, and we are the professional body for nursing, as well as being the largest trade union. So we were very well placed to get all of the experts around the table to think about what should the standards be for the nursing workforce. And I've shared the link with yourselves, and hopefully everyone can have sight of that. But please look at what we've set out in these 14 standards for the nursing workforce. Now, particularly the conversation we've just been having about ward managers. Standard 5 talks about there needed to be a registered nurse lead for every team that is primarily nursing. So that's pretty much your ward managers, your unit managers, community managers, nursing home managers, etc. But standard 6 really sets out why it's important that they are 100% supervisory, so that they have the time to do everything we've just been talking about, the time to value the workforce. Now, you might think we haven't got enough staff, so how can that happen? Actually, if you invest in that and give the time, those wards will be successful. They will recruit and they will retain their staff. And you'll be interested in all of the other standards. Standard 8 sets out uplift, having the time to do that planning, having the uplift within the establishment to actually be able to manage and not be reliant on agency and bank staff. So I think we feel that we've got all the answers within the nursing workforce standards. What we know is that virtually no organisation at the moment would be able to put hands on heart they can achieve all those standards. So that's where we need and we're lobbying for the government to, one, publish the workforce plan, but also have the funding that follows that to make it actually achievable, so that those nursing workforce standards can be achieved.
We'll go back to the government thoughts in a minute. Just want to bring Naomi back into the conversation. Naomi, I gather you do annual workforce planning exercises, which are national operations. What do they involve, and how useful are they for you?
So I think obviously every trust has to do their annual kind of return with their annual planning. What we're really trying to get into a position is that it's an ongoing process throughout the year, and when we get to submitting those annual plans as part of our business planning process, it is really relevant, and it's relevant and live information, rather than people kind of trying to pull it together at the last minute. I think one of the most important things really is the triangulation. I think this is with all of the workforce planning activity and the workforce. So, you know, I think sometimes workforce planning as such is seen very much under the workforce agenda. However, you can go off and work with departments and say, okay, well, we need to look at your skill mix, we need these new roles, we need to look at A, B, and C. But actually, unless that aligns to the finances that are available and are there, and how we're going to use those finances, and unless it aligns to the activity and the demand and how that can be provided, it's not really got any basis for a plan. So I think, you know, one of our main focuses within my trust is really trying to get that triangulation right, and all of finance, activity and workforce having some kind of common language and thread, so we're all in line with each other.
How do you do that, Naomi? Because that sounds quite difficult a task to me.
Yeah, it is very difficult. I mean, the first thing is ensuring that you have those correct representations at those meetings in those projects. You know, just a really simple example would be for the annual plan this year, we had a kind of joint spreadsheet that looked at, for example, the impact of COVID, what our workforce looked like for COVID escalation beds, what the finances looked like for those COVID escalation beds, and what the numbers in terms of patient demand and activity looked like. And we could just see very simply whether there was some kind of correlation, you know, and we did that in a number of different areas to say, actually, are we all kind of starting from the same point? Because actually, if something changes in terms of the demand, that's obviously going to impact the number of the workforce we need, and it's going to impact the cost of the workforce, whether we have to go bank and agency. So they're so interconnected that we just tried to lay down all the basic foundations to say, are we actually all working from the same place?
Oh, that sounds a really good place to start. Mira, how do you identify areas to focus on when you're trying to drive improvements?
So, I mean, the NHS is sort of flooded with data, and I think there's something about being able to sift through that massive deluge of information that we get to find the right kind of indicators. And there are loads of loads. I mean, clearly Model Hospital is a really good source of information in terms of productivity, in terms of activity, and in terms of just identifying where we benchmark as an individual organization against comparator trust. So we look at that on a regular basis. But I think there is real power in triangulating all of that information with normal workforce indicators, for example, turnover, sickness absence, vacancies, to identify spots that are of concern. And I mean, those initial projects that I described came out of this kind of triangulation. And then I think quite importantly, around understanding data and identifying areas is really the point that Michael made earlier about empowering people to actually use that data and to use the stories that they have to be able to actually take things forward. And just as a quick example of that, I think most NHS acute organizations are struggling with, for example, the number of midwives that they have. Nobody has enough staff. And so our teams, our midwifery service, looked at their data, looked at the likely pipeline that they had, when they're likely to be able to recruit, etc. And because they knew that they would not be able to get sufficient numbers, they came up with a solution, which I think is so simple, but has really transformed the way they run their service. And what it goes back to the whole theme around rosters. Most wards will have quite regimented rules about a roster, a shift which starts at, say, 7 in the morning, runs until 7:30 at night, and then another one which starts at 7 in the night and goes on to the next morning. And instead, what they said is that rather than forcing people to pick the shifts that we have, what they offer is something that they called any hours. So they tell their midwives, pick whatever you can do whatever you can do. So if you can only work from 10 in the morning till 11 or 10 in the morning till 12, well, do that. And that has meant that their agency bookings have absolutely plummeted. It means that they have far more of their staff willing to pick up additional hours. It means that they are better staffed than they've ever been before. So they're giving all kinds of commendations. So there's something about looking at the data, but there's something about using the data to identify those areas of focus, But really importantly behind that is to give the people who know this best the power and the authority and the tools to be able to actually come up with the solution that will make a difference.
I think that came up, Mike, didn't it, on our panel this morning, that the kind of any hours thing and how it works. And I know you're a great fan of data and analytics to support a more effective workforce management.
Yeah, it's the thing about, as Mira said, there's an awful lot of data in the NHS, but paradoxically, there's not quite enough of the right data. And if you go like to ESR, for instance, electronic staff record system, the quality and consistency of data in there is poor, and there's a lot of information that's held electronically about staff, but it's not held in a digital format. So quite often people's staff records will be in a PDF stored in a folder somewhere, and that's not digital information. It's not information that can be analysed easily. So it's about trying to find the right data that you can get hold of, and then making best use of it. But I really, really resonate with what Mira's saying about empowering people. The NHS is a very hierarchical organisation, set of organisations, and I have the benefit of going around to many NHS trusts, trying to help them improve the way they manage things around workforce. And you talk to people, they just feel as if they lack some empowerment. These are really bright, intelligent people with sometimes decades of experience and really wanting to help and support both the organisation, improving patient care, as well as their colleagues. But quite often they're not given the tools and the resources and the ability to go and do that, which is why I think what Wendy's saying around the nursing standards is really important. How you go and implement those standards, which say, maybe it's something that NHS, particularly the provider trusts, need to grab hold of and say, okay, perhaps there's a benchmark of how many nurses we've got who have 100% supervisory role and are able to deliver that kind of stuff.
Yeah. Wendy, you talked very eloquently about the support from the Royal College of Nursing, but just started to touch at the end of your answer on the government. What do you feel the government could do to better support the nursing workforce? What do you need from government?
I mean, before I talk about what we need from government, I think some reflections of what we've seen as we've been in lots of organisations during industrial action and what we've seen on the ground. What we've seen on the ground is a massive difference between what is the establishment for all departments and everywhere. There's a massive gap between establishment and reality. That's what we've seen on the ground. And also, and this is one of the key issues we talked about at our Congress a couple of weeks ago, is the pressure across all settings around corridor care. So patients not just queuing outside hospitals, but in the corridors all over the place, not just in ED, and boarding this. Lots of organisations having extra patients in the middle of bays, whether they be on a bed, a trolley, or sitting out, and that is a massive problem. What we're calling for the government to do, and we've got a document that lots of documents on our Staffing for Safe and Effective Care site, which are available for anyone to look at. We're asking the government to deliver a fully funded health and social care workforce plans to ensure that long-term retention and recruitment that meets the needs of the population, and that it's not based on the it's based on the needs of the population, not the purse strings. We need them to publish independently verifiable assessment of where health and care nursing workforce requirements are now to meet the need of that population and to address some of the health inequalities and the inequalities within the workforce we talked about earlier. But also to ensure that the government is accountable. So this is particularly for England. The government needs to be accountable for that nursing workforce, both in the planning and the supply in law. And we know in England, we're just not getting any traction for agreement. We're seeing positive movement in the devolved countries, but not in England.
Wow. Naomi, slightly going off now on a bit of a tangent from what Wendy was saying there, but how better can leaders organise the workflow to suit the resources available? I mean, one thing we touched on there was the sort of those real flexible hours, but what are you doing to try and organise the workflow to tally with the resources you've got to hand?
I think one of the things is about understanding really within each area where the kind of issues are, and what you can change and what is out of your control. So one of the things that at the Trust we've developed is workforce dashboards, and we're just in the middle of developing one which looks specifically at EDI metrics within each area. But what it allows is for managers to actually focus down on their particular area. So, not at a really high level, but they can really focus down and see within their staff groups, within their different departments, where are the issues. So, for example, with turnover, how long are people staying? Have they got a high amount of people within a specific area leaving within the first year, which actually is an outlier of the Trust? And with time pressures and everything else, it's really about where can you prioritize and focus that time. So I think it's about making sure that people have the right information to be able to spend their time in the right place and really look at what things they can control and what things they can impact within their area.
Mira, most conversations around productivity tools aren't necessarily exciting and interesting for staff, and in fact sometimes perhaps can be seen as threatening. But how do you do it in a way that keeps your teams and staff engaged and motivated? How do you make it interesting and make people have appetite for it, if you like?
Yeah, and I completely agree with you. I mean, the moment people talk about rosters and roster rules and roster efficacy and job plans and how much activity is going through job plans, people see that as a direct threat to the work that they do. And I think it is a really tough balance to get right. And I think the key for me, I mean, as Chief People Officer, the key to it is making sure that as many people in the organization as possible feel that they have a stake in those solutions that are designed. So whether that's, if we take it back to the example around rosters, for people to feel that if they design it right in a way that works for them, those rosters will automatically be far more effective than they would be otherwise if my team just came up with a policy that we thought ticked the boxes. I mean, it is a real tragedy in the NHS, it has been a tragedy in the NHS, that most workforce policies, for example, are written for that small minority of maybe 3% or 5 or 4% of staff who are going to breach the rules, and not focused on those 95% of staff who just want to do a good job. And I think if we are able to shift that concept in the way we work and are looking at proactive solutions, staff will always be engaged. So just as an example, it's not truly about workforce management, but I think many NHS providers are struggling with with issues around violence, aggression, and abuse that staff experience from patients. And it is possible for us to put up posters and design them quite easily without involving staff. But some work that we've been doing, which is with focus groups that have involved staff across the organization, it means that we have at our Trust an action plan that runs into about, I think, 70 to 80 items. Each of those items is a suggestion that has come from frontline staff because they feel that they have a stake in the outcome that we come up with. And I think that is really key. If we are able to navigate that relationship and make sure that staff have a stake in those solutions, I think they will be engaged.
I think, Mike, when Naomi was talking about dashboards there, what just popped into my head was, how important collaboration is. And, you travel around and you work with trusts all over the place. How can we perhaps better enable trusts to collaborate and deliver training and workforce management at scale, being inspired by ideas that are already working in other areas?
Yeah, and I think that's where the ICSs have an opportunity to bring people together. There's always been a bit of reluctance amongst individual providers, to join forces and team up. And NHS, particularly the acute sector, they do things differently for very good reasons, geographic reasons, demographic reasons, the types of services they provide, and so on. But underneath it all, there's a workforce. It's not one workforce, but essentially it is a workforce. And I think it would be really good if individual ICSs, the chief people officers and the HR teams could kind of get together and start collaborating. Pick a topic, just pick one. Let's call it internal recruitment. and let's say, how can we standardize the approach to staff moving between individual trusts? Can we all agree on a standard around DBS checks or reference checks or occupational health? Can we recognize each other's, training standards? It's finding a topic and starting small. This is a really, really complex problem, and dealing with something really difficult. It's like, how do you eat an elephant?
Yeah, not whole. It's definitely not whole. It also, I always come away from these events, as some of you on the panel know, I host a lot of them, and I always come away feeling quite thankful that we've got the brains in the NHS that we have, on all the panels and with our speakers, because it's wonderful to see what goes on behind the scenes. It's very easy to get carried away with negative headlines in the press. When things go wrong, that's the only thing that ever makes news, when things go wrong or somebody spent hours on a trolley and not had a happy outcome. But actually, I feel inspired by the fact that all this work does go on. And that's why I think collaboration is key. And particularly when different trusts have come up with something unique or different that works, it's so important to share that, which I hope this event also gives you the opportunity to do. We've got a minute left, Wendy, and I'm going to give you the final word, because I think with all the stories of burnout and exhaustion and all these kinds of things, give us a positive minute on why should someone consider a career in nursing?
So I've been a nurse for 33 years, and I think it is the best profession ever. It is difficult. It is complex. We're dealing, in my 33 years, I've seen, nurses become a graduate profession, safety critical profession. The work is so complex, but it is also fantastic. And you have a great opportunity to change lives of people, families, populations, and so I think it's fantastic, and I'm really pleased that I'm going to be, as part of the RCN, developing the first ever overarching UK professional framework for nursing. So watch this space. Later in the year, beginning of next year, we'll be able to show you what is nursing in one place, which hopefully will recruit and retain the nursing workforce we need.
Well, I hope you'll come back and share that with us. Another great discussion. Time's flown again. So I'll say massive thank you to Mira, Wendy, Naomi, and Mike. Thank you for being here. It is time now for our final networking break, where you'll be able to connect with all the delegates that have joined us today. And after the break, our final panel discussion on the important topic of mental well-being. I'll see you at 3:10. I said in 10 minutes.